getting into the home stretch, or as Dr. Klempner would like to talk about, in the fourth quarter. And I actually just flew back from Boston last night. It was 30 degrees and there was snow everywhere. So I understand why he left and came here. And so it was so nice. I get off the plane with my heavy jacket last night, and it's warm even on the west side. And driving out, I was thinking, I'm so glad I'm not in Boston. The other reason, of course, is that the driver who took me from the airport, unbidden, started talking about the Pats. And so, can you hear me? Okay. The other thing I'd like to say would be, I really want to give, really a lot of thanks and really just amazement at actually Dr. Klempner and Debbie's dream for putting this together. This, as someone who works with advocacy groups and has given lectures to, particularly to lay and to sort of mixed groups, this is an amazing turnout, and I think it really is a testament to both nationally and locally what they've been able to do, and I really thank you for inviting me. So my name is Randy Hecht. We have anglicized it, though Dr. Lenz continues to pronounce it as if my ancestors were still in Germany. And so one day I will move back. But so I'm at UCLA. I run the GI cancer program there, and we've been working with gastric cancer and had an interest in gastric cancer for a long time. But as I think the previous lectures showed, is that we're not doing as well in gastric cancer as we would like. And as someone who takes care of patients every day, Monday through Friday, and sees gastric cancer patients, even though some patients do well, I know we're not doing as well as we would like. And while precision medicine is extremely important, and in fact standard therapies still have the bulk of the benefit of what we do, whether it's surgery, whether it's standard cytotoxic chemotherapy, is that the question is how can we move to the next step? And while we were sleeping and doing this, the immunotherapy revolution happened. And over the last 5 years, we have diseases that really had treatments very similar to what we have in gastric cancer. They had precision medicine, they had chemotherapy, they had surgery, and now some of these cancers, we're not really quite whispering the cure word yet, but some of these patients are doing well for a long period of time. And so what I say is that now it is time to join the revolution. The revolution is all around us. We tend to divide cancers up into different histologies depending on where it comes from. But the good news is that a lot of the things that may be helpful in one type of cancer may also be helpful in other types of cancer. So particularly for lay people, why do we have an immune system? And basically the reason we have an immune system is that we live in a dangerous world. We are surrounded by potential invaders, bacteria, viruses, that would love to feed on us. And the immune system has developed over hundreds of millions, if not a billion years, basically to keep us safe from that. Now on the other hand, and this is also really important, is that you can't be on a war footing all the time, okay? There's no politics in there, actually, but you really can't. And so because if you have your immune system revved up all the time, it basically will attack normal tissue. And in fact, there are also advocacy groups for those diseases, like lupus or rheumatoid arthritis, or even asthma, where this has gotten out of control. And so this is a very highly controlled thing, where most of the time your immune system is turned off. And that's important because otherwise you would be really sick. Now, the final thing is that if your immune system were working perfectly, then we would not have this meeting. And the reason is because by definition, cancers, even though they come from you, are different. And that in everyone who comes to a doctor with gastric cancer, with other types of cancer, and particularly in metastatic cancer, is that the immune system has failed. It has not recognized these cells as being foreign and has not attacked them and gotten rid of them. So there are a lot of mechanisms, and this is actually more for healthcare givers in the audience, but anything that's this important is really highly regulated. Because otherwise what would happen, once again, is that people wouldn't survive long enough because of their immune system. But there are a number of things that have to happen in order for someone's immune system to really take notice of a cancer and begin at least taking steps against it. First of all, it has to recognize that it's foreign, and there are a number of ways that can happen. And I'll talk. There's no pointer, I guess. Finger, the long arm. And so I had one. I think I have one in my bag actually from the meeting yesterday. But basically, there are ways that we're able to recognize these as far, and some of which by having these tumor cells die. You have to get the what are called cytotoxic T cells, basically the cells that kill tumor cells, you have to get them into the tumor. Also, you have to turn off a number of the mechanisms that keep these T cells from, pointer? Oh, thank you very much. So I'm the next to last talk, so we have the pointer. So Heinz, it's all yours with the pointer. Yeah. And so so you need to be able to turn off things that basically turn off the immune system. And people who are much smarter than I am spend their whole careers in immunology looking at these. And then finally, we need to also be able, this is also once again, being able to take these abnormal proteins that are on these tumor cells and feed them to the immune system so it recognizes things. So one of the most important things that we work with, and this is the cutting edge, this is the point of the spear in immunotherapy right now, what are called checkpoint inhibitors. So these immune checkpoints basically are at least some of the most important things in turning off the immune system so that these T cells, these cells that would attack the invaders don't attack normal cells. And your normal cells have what are called checkpoints, and these form a connection, sometimes called an immunologic synapse, where they basically tell the cells, these immune cells, that for those of us who are a certain age, these are not the droids that you are looking for, okay? These are not abnormal cells. Now, for your normal cells, that's great, but if they're immune cells, that's a bad thing. Excuse me, if they're tumor cells, that's a bad thing. So the point is that these become a target, the things, and the ones that have been the most important, the first one was called CTLA-4, and you can see that this both on the tumor cell, there's a connection between the T cell and a tumor cell or an antigen-presenting cell, and the other one is PD-1. And when we block these, there's the potential for long-term benefit. So really the first cancer that this was shown to be important in was melanoma. Now, melanoma, for those of that you don't know, that is the bad skin cancer, basically, the one that's counted in the cancer statistics, unlike the ones that people get burned off at the dermatologist. This unfortunately kills, it's not that common, but it kills a reasonable number of people. But we've known for a long time that immune therapies actually have some activity. And this goes back, decades with things like interferon, various what are called interleukins. Even some vaccines have had some, even people on their own without immune therapies could have a benefit in immune therapy. One of the people at UCLA, Tony Rebus, was one of the first people, though there were also people actually in town who also worked on this and was able to show that checkpoint inhibitors, first CTLA-4 and then PD-1, showed a couple things. One is that these are patients who generally had failed all prior treatments. And what you can see, this drug, which I'll talk a little bit more, called pembrolizumab, which is also called Keytruda, and this is a trial that Tony published. Tony is also the head of the Parker Institute of Immunotherapy at UCLA. It's one of a few places around the country that has one. And in Tony's trial, you can see that different doses of patients who ended up getting pembrolizumab as opposed to standard chemotherapy, and there are a number of trials like this, ended up doing better. I think this has been talked about before. This is a Kaplan-Meier curve. Basically, everyone starts at 100%. This is with time, and what you can see is, one, they did better. The other thing that's really important with immunotherapy, as opposed to small molecules and signal transduction inhibitors that I've spent most of my career working in chemotherapy, is that this is what a curve in chemotherapy looks like. Eventually, almost everyone dies. And the big difference with immunotherapy is that if you look, we sometimes call this a plateau or a tail of the curve. Not only overall did patients do better, but there's at least, the numbers are small, but this has been borne out in multiple trials in melanoma and some other diseases, is that there's at least the potential for long-term benefit. And we're still, many of these patients are still alive, and even some of them are even off the therapies. So this is the goal. This is really what we would hope to have also in gastric cancer as well. This is also, but as I said, melanoma is a disease that we already knew immune therapies work. But what about diseases where immune therapies really don't work particularly well, at least the standard ones? And the one that's actually the most common cause of cancer death is lung cancer. And Eddie Guerin, who's also at UCLA, his office is next door to mine, ran the first large trial, once again with pembrolizumab. And what you can see is that this goes back, and I think Dr. Klempner was exactly right in talking about the intersection between precision medicine and immunotherapy, is that these drugs, they have a target. I mean, these are artificial distinctions. They have a target, and this one of them is called PD-L1. And patients who have scoring and have a lot of it do much better than people who don't. So, but at least right now, this is a disease that kills almost everyone in the first year to two, and then if you look at this group of patients, that a lot of them are alive for a long period of time. And what we know is that these patients actually, with more time, actually continue to do well. So why would gastric cancer be interesting? So one of the things that's been looked at is that when you look at the cancers that seem to be really interesting at least from a PD-1, these checkpoint inhibitors, they tend to have a lot of mutations in the tumor. I know this has been talked out before about specific mutations. This is just the gross number of mutations. And in fact, if you look, melanoma is out there together with lung cancer, and look what's right next to it, stomach cancer. And so the idea is that that stomach and esophageal cancers may actually be something that would be a good target for this. Oh, this works for both. Actually, this is the same slide that Dr. Klempner showed, but I just blew it up a little bit because my eyes are not as good as yours. And so I'm probably the oldest person here, except perhaps Dr. Lentz. And so I probably am older. And so my second career. And so what we know, and this goes back to this TCGA, though the thing I have to say is that almost all those patients actually did not have metastatic disease with the TCGA. So we really don't know, and some of the work that we're doing and others are working, and as was talked about in the precision medicine talk and others, is that not only are the mutations might be different, but it's also a moving target because the mutations may change as you treat patients. But there are at least 4 separate groups of gastric cancer if you look molecularly. But what's particularly interesting is that there are at least 2 of those groups may have markers that say that they could be really sensitive to immune therapies. There's about 10% of patients who have lots and lots and lots of mutations. I think someone mentioned Lynch syndrome before. Some of those are inherited predispositions. Otherwise, this is another way to gastric cancer. The other is that patients, there's actually not just Helicobacter, as was mentioned, but also, particularly in some parts of the world, that Epstein-Barr virus, the same virus that causes mononucleosis and a rare type of actually head and neck cancer, nasopharyngeal carcinoma that's common in China, that also is associated with gastric cancer. And these patients have a lot of overexpression of the target that may indicate that immune therapies, checkpoint inhibitors, may work. So the first real information that we had with this is from a small trial that Dr. Lee at Johns Hopkins and really run by and put together by Luis Diaz was looking at patients who have lots and lots of mutations. It's called mismatch repair deficiency. You'll also hear it called MSI. Basically, the spell checkers of the tumor, the spell checkers that look to see whether there are new mutations in DNA, sort of like what Dr. Klempner was saying with this texting, that more and more mutations build up. And remember, having lots of mutations may wake up the immune system to attack the cancer. These people have thousands of mutations. And in fact, they're talking about colon cancer, but they also looked at other cancers as well. This is what happens when you see this is melanoma, which has more. This is actually colon cancers and regular GI cancers, such as gastric cancer. And these are these patients who have mismatch repair, over 1,000 mutations per tumor. We don't necessarily know what they do. They may not all be important, but they may be important for getting an immune response. So when you looked at this is the same drug, pembrolizumab, that I showed results with, though there are other drugs that are very similar, such as Nivolumab, which is sometimes also called Opdivo, atezolizumab, which has just recently been approved. There are a number of other ones that are all very similar, and I don't think there are huge differences between them. But with this, what you can see is that patients who did not have lots of mutations, these are the ones that are red, had no benefit, while those patients either with colon in green or black, which included, I believe included some gastric cancer patients, had a lot of shrinkage of their tumor. That would be nice, and that looks sort of like what we see with a successful chemotherapy or targeted therapy. But instead, this is what's perhaps more important, is that when you look at patients who didn't have lots of mutations, they actually they necessarily didn't do well. If you look here, On this part, the ones that had MSI or abnormal DNA mismatch repair, lots and lots of mutations, not only did they do well, where about 90% of people got some benefit, but about 60% had significant shrinkage and perhaps long-term benefit. And in the discussions with that group, some of them are actually doing well off therapy now. So this may be up to about 10% of patients with gastric cancer. The question is, what do we do with the other 90%? Sort of like Wall Street. So it turns out that there's already been a number of trials, small trials, looking at these checkpoint inhibitors, either blocking this other checkpoint called CTLA-4, or either side of that connection, PD-L1, like atezolizumab, or PD-1, like pembrolizumab or nivolumab, and we're beginning to see some some benefit, and people have already started looking at combinations. First large trial that was called Keynote 12, and this was presented by Dr. Murrow. Now it's been 2 years ago, and what you can see is that, once again, not only do people sometimes have shrinkage, and all these other small trials look like it. This is sometimes called a swimmer's plot, where you see how long people did and stayed on. Basically, there's some people who did well for a long, long period of time. And this also shows not only did they do well for a long period of time, but many of them, their tumors shrank. So this finally led to a phase 3 trial. As Dr. Klempner and I think Dr. Lentz were saying, you have to have data to say, do the patients do better? So this is a very similar drug, nivolumab. This is a trial that was only done in Asia. Dr. Kang, who from Asan Medical Center in Korea, actually was the first author on this. This was a randomized trial versus nothing in people who had had prior therapy. They had best supportive care. My original slides were white, so hopefully this shows up a little bit better. But what you can see is two things. One, the patients did better. Two, the numbers are small, but it seems to be like in the other trials, about 10 or 15% of people do well for a long period of time. Patients don't say, Dr. Hecht, I just want to have a good scan in 2 months. People ask, Dr. Hecht, what I want, or any of the physicians that are here, what I want is to be around for a long time. And that's what they may be seeing. So how do we do better than 15%? And the question is that it gets a lot more complicated than that. And I have 20 minutes to go on this, or else Dr. Lentz will physically remove me from the stage. And so one is to combine with some of the things that have already been talked about. And that by killing cells and releasing these tumor antigens, particularly radiotherapy, which sometimes is called the abscopal effect, you may actually interact with all these things that I was talking about in the anti-angiogenic agents, as Dr. Chow was mentioning before, like ramucirumab, targeted therapies. A lot of my work has been with viral therapies as well. We'll talk a little bit about. It turns out that anything that's as complicated as the immune system has lots of different ways to regulate. There are other checkpoints, and the ones we're particularly interested, such as LAG3 and TIM3. There are other parts. And there are other parts of the immune system which you can turn on, like what's called the innate immune system. And we're particularly interested in cytokines as well as in cancer vaccines. I'll talk just very briefly about this, I promise, Heinz. And so these are trials, actually most of which are open by my colleague Zev Weinberg, who was actually supposed to give this talk, but unfortunately had a family commitment. These, if you notice, the big thing is combinations. These are with chemotherapy or in maintenance or combinations with other targeted therapies. We also have a trial that I put together and I'm running that's an international trial with injecting a virus it's been approved in melanoma as an anti-immune effect, as well as another trial we put together with other checkpoint inhibitors that are open now. Just to talk very briefly, if Heinz will let me, this is our viral trial. The drug is called, and I'm the only one who can pronounce it, Telimagene Vorapek. Which is not German, and so it is actually a herpes virus that is, as I said, has been shown in melanoma. It also encodes for an immune stimulant, and we actually are injecting it directly into metastases into people's livers. We're kind of working that up and looking at combinations, but right now we actually we'll be accruing patients with gastric cancer as well. And that's just how we do it. That's together. We also have other trials, as I mentioned, about TIM3 and upcoming LAG3, which are other checkpoints, hopefully able to get beyond the 10 to 15%. So upcoming trials, just so that, and I think this happens to be UCLA. I don't know what's open at USC or across the street at the Angeles Clinic or at City of Hope, and they can talk to you about this. There's something I'm particularly interested in, which is pegylated IL-10. That's why I was in Boston for this trial that I'm running in pancreatic cancer, but we're also looking at gastric cancer as well. This is something I think is very interesting that we're specifically looking at, which are personalized vaccines. We talked about personalized medicine. Zev Weinberg will be actually running a trial at least the UCLA part, looking specifically at personalized, trying to say what are the mutations and get a vaccine against them. I'm running a larger trial, a nationwide trial, but unfortunately that's only in colon cancer. There are other things that we have a real interest in. Whoops, sorry, back. In injecting tumors with immune stimulants, and I think that's something that will maybe be for the future. This is actually the most fun talk to give because I'm actually not limited by data. I can just talk about what's going on in the future. But these are exciting times. Dr. Chow said, what would I be doing in the next 30 years? Wow, 30 years from now, I will probably be in a nursing home. But if you want to know that for the last 20 years that I've been doing this, is that these are exciting times. Now, that's a little bit cold comfort to the patient who says, what can I put you on right now? But I think for those of you who are here to realize that when I started in working with HER2 and signal transduction, those were interesting. These are beyond interesting. These are really, truly exciting times where we have the potential, before hopefully I retire, that to actually cure these patients, the patients who are out there, and the patients not just in this room, but everywhere, the potential to cure these patients with gastric cancer. And with that, thank you very much.